Hello, I'm Dr. Troy Woodard of the Cleveland Clinic Head and Neck Institute, and today I will be discussing how to avoid complications in endoscopic sinus surgery. These are my disclosures. During today's talk, we will have a brief overview of complications during sinus surgery. We will also discuss principles on how to prevent these complications. We will then discuss minor and major complications, and then sum up how to prevent these horrific complications. So Benjamin Franklin was a wise man, and actually he said a quote, "An ounce of prevention is worth a pound of cure." Now, you may not think this has anything to do with sinus surgery, but hopefully after today's discussion, you will actually see how what he said, hundreds of years ago can actually be applied to endoscopic sinus surgery. So back in 1987, Dr. James Stankiewicz actually performed the first early large series describing complications in patients undergoing endoscopic sinus surgery. He looked at 90 patients, and what he found was pretty alarming. He discovered that there was an overall complication rate of approximately 29%. In addition, he found that the complications were primarily what he described as major and minor. So he categorized these different complications into major events, which were generally CSF leaks, temporary blindness, or massive hemorrhage. And he contrasted those with minor complications, primarily SYNECHIAE. He found that major events occurred about approximately 8% of the time, and minor events occurred approximately 21% of the time. Now, over the past few decades, endoscopic sinus surgery has become more commonplace. And actually, recent studies have described a decrease in incidence of these complications. As a matter of fact, major complication rate is now approximately 1%. Now, this can be attributed to a better understanding of the endoscopic anatomy, as well as a refinement of surgical techniques. In addition, there's been a lot of technological advances. We have improved image quality so we can see what we're doing better. We actually have better instrumentation, and now we can have more precise navigation systems. So there are several risk factors that can predispose patients for complications. One, patients who have extensive sinonasal disease that are primarily caused by pansinusitis, obstructed nasal polyps, sinus mucoceles, fungal rhinosinusitis, and tumors are more likely to have complications. In addition, patients who have had previous sinus surgeries and have anatomical variances and abnormalities are more likely to have complications during endoscopic sinus surgery. Now, there are several principles that you must take in order to actually help prevent these dreaded complications. First, when you're seeing a patient, you should do everything possible to make sure that they're geared up for surgery. So oftentimes patients are on numerous medications. So you should look at their list of medicines, make sure that they're not on any anticoagulants. And if so, you should stop them and make sure obviously you have to check with their cardiologist or medical doctor, but if possible, it's best to see if they can stop the anticoagulants, antiplatelet agents. And then, it's also important to check and make sure that the patient is not on any supplements. Oftentimes, you have to specifically ask the patient if they're taking any vitamins or any other supplements, because a lot of times they don't necessarily consider them medicines. And oftentimes they don't know that medicines such as ginkgo biloba or ginseng or garlic or vitamin E can cause thinning of the blood. In addition, if you look in their history and you see that they have a history suggestive of a coagulopathy, you may want to send them to a hematologist to get a proper workup. Lastly, during an exam, if you notice that they're very inflamed, studies have shown that, and anecdotal evidence have shown that severe inflamed tissue is more likely to bleed. You may want to consider preoperative prednisone. Possibly a 7 to 10 day course could decrease inflammation and help reduce, bleeding, which could help you during your operation. As the surgeon, it's very important that you actually have a master or a good understanding of the surgical anatomy, the sinonasal anatomy, right? You need to familiarize yourself with the patient's anatomy because every patient is different. So you need to have a good review of the preoperative scans. At our institution, we use a standardized checklist. It's also important to use a navigation system that you're familiar with and that's also reliable, easy to use, and is accurate within 1 to 2 millimeters. One mnemonic that we like to use is the closed mnemonic. So first, we take a look at the cribriform plate, and it's important to look at this region to assess for the Carroll's classification, right? You're looking for the height of the skull base. You're looking for any asymmetries. You're looking for any dehiscences. Next, we take a look at the lamina paprica. Again, checking this area out for dehiscences. You're looking to see where is the uncinate. Is it contacting the lamina? Are there any Howler cells? Next, you want to look, the O stands for nodi cells. Is there a nodi cells? If so, you have to be wary of dehiscence of the optic nerve within this cell. The S stands for sphenoid sinus pneumatization, right? And so this is important, especially when you're dissecting in the sphenoid sinus or opening up the sphenoid sinus. As we'll discuss later in this presentation, there's a possibility of dehiscence of the carotid as well as the optic nerve in this sinus. Lastly, the ethmoid artery. As we'll discuss later, the anterior ethmoid artery oftentimes hangs on the mesentery and can be predisposed to injury, which can lead to massive hemorrhage and retroorbital hematomas. So after you have prepared the patient and you as a surgeon are ready, you're in the operating room, and it's very important to have to optimize your surgical field. It's important to note that most major complications actually occur in the presence of excessive bleeding. So what we try to do is to minimize the excessive bleeding during surgery. There are several things that you can do as a surgeon to help minimize this. One is to use TIVA, a total intravenous anesthesia. If that's available for you to use, oftentimes you may have to consult with your anesthesiologist to see if they're willing to do that or if the patient is an appropriate candidate for that type of anesthesia. Generally, we try to request that the mean arterial pressures are between 65 and 70. We tend to have the head of bed elevated at around 15 or so degrees. We also use vasoconstriction through topical and injectable agents prior to surgery. So we'll use oxymetazoline to spray the nose prior to beginning the procedure. We may put pledgets in the nose as well. We can also inject with lidocaine with epinephrine. During the procedure, we use warm saline irrigations to help maintain platelet function. And again, as I mentioned earlier, it's important to avoid areas where the arterial vessels run. So the anterior ethmoid artery and the sphenopalatine artery branches, is important to identify them during your surgeries and to avoid or to cauterize them if they're injured. So now that we've talked about preparation, it's important to now move on to the various types of complications. Generally, complications are divided into major and minor complications. There is a distinction between the two. Major complications are those complications that generally require hospitalization and usually take back to the operating room. As mentioned earlier, compared to that previous study by Dr. Stankiewicz, the major complication rate has fallen over the past few decades and is approximately 1%. So first, let's start with minor complications. SYNECHIAE, the dreaded SYNECHIAE. This usually occurs when you have two open wounds that come in contact during the healing process, and they actually heal and scar together. Ways to prevent that is really to have a meticulous tissue handling. As you can see in the figure 1, in the picture on the right, this demonstrates an adhesion between the middle turbinate and the lateral nasal wall. Now, oftentimes, this can occur because of several reasons. One is sometimes I have seen where the septum is rather deviated, and I have thought, well, I think I can get in this area and operate and work in this narrow space, and I'm able to do it and decongest well during the surgery. However, post-operatively, the tissue kind of swells, and unfortunately, I'm unable to really debride as well as I would like. And those two areas come in contact and heal together. So that's one possibility. Other possibilities could be that during the operative surgery, you can destabilize the middle turbinate to where it doesn't have the support that it normally has, and so it becomes floppy. And so ways to kind of prevent this lateralization of the middle turbinate could simply be by putting in a spacer. You could put in something like a nasopore or some type of stent to keep the middle turbinate over or medialized along the septum. You could actually suture it to the septum. You could not destabilize it in the first place. So those are things that you could do to just sort of prevent this. Also, as I mentioned earlier, working in a narrow space could prevent future debridement. So you could, if you can see that you're working in a narrow space, you might want to consider doing a septoplasty up front. This will allow you to have ample room, and then in the postoperative phase, come in and debride. And if you see that it's starting to lateralize, put in a spacer after the fact. Next, we have infection. Oftentimes this can occur when there is inadequate or improper resection of diseased sinonasal tissue. The picture to the right actually demonstrates maxillary antrostomy that has recirculation. And there is an incomplete resection of the uncinate process. And what you see here is that the natural ostium is not connected to the antrostomy site. And so in this patient, they're predisposed to having recurrent infections because the mucus just recycles out of the natural ostium through the antrostomy site over and over and over. One way to prevent this is actually completely removing the uncinate process and connecting the natural ostium to the antrostomy site. You can have minor orbital complications or anisocoria or asymmetric pupils, which could occur by having topical or injectable local anesthesia, which can cause nasociliary ganglion blocks. You could also have a violation of the lamina papricia. This could lead to periorbital fat exposure or periorbital ecchymosis or periorbital emphysema. So if you do happen to violate the lamina papricia, there's a few things that are very important to do. You need to avoid manipulating this region because you can expose or cause more of the fat to become exposed. This in turn will help protect extraocular muscles and the optic nerve. It's important to tell the patient not to use large volume irrigations, and to also, what I've done in the past is if they have to cause or cough or sneeze, to also kind of put pressure over their eye and at the same time. The reason being is because of the defect in their lamina, they're predisposed to developing emphysema or having air going into their orbit. So you want to prevent that. You want to try to prevent any sudden increases in like any intraocular pressure. You don't want them to strain or have any nose blowing, vomiting, or coughing. So it's very important to communicate with anesthesia during the wake up. Oftentimes you will tell the anesthesia, hey, there's a dehiscence in the lamina, so I need you to maybe provide like a deep extubation, or if you can, a gentle extubation of this patient. And again, during the extubation, you might just want to hold pressure over the eyes to kind of prevent any excess air from going into the orbits. So now let's move on to the major complications. Bleeding. This is actually the most common intraoperative and postoperative complication from sinus surgery. It can be divided into minor and major. The minor generally occurs from venules and arterioles supplying the nose and sinuses. This typically requires anterior packing and or silver nitrate cautery. The major, however, is a lot different. It's generally from larger vessels, the anterior ethmoid, sphenopalatine or posterior septal arteries, and or the internal carotid artery. This typically requires hospital admission, posterior packing, and or take back to the operating room. This diagram just further illustrates the arterial supply of the nasal cavity. And as you can see in the blue area, this is the primary area of most nosebleeds. This is the anterior part of the nose and Kesselbach's plexus. Generally, this area is able to be controlled by anterior nasal packing and or silver nitrate cautery. You get more concerned, though, as a physician or a surgeon when the patient has bleeding from the other locations further back. Generally, these require the patient to be packed with a posterior pack, admitted to the hospital, and possibly surgery and or embolization. Now, after surgery, some mucosal bleeding is expected. And in order to prevent this, there's several techniques that you need to do. First, try to operate in an atraumatic technique. So avoid scraping the septum, avoid, being aggressive on the mucosa. If you're going to medialize the middle turbinate, do it very gently. Again, try to avoid the arterial branches. So if you are open up the maxillary introstomy and you're making a wide introstomy, remember posteriorly, you're getting close to the sphenopalatine artery. So be careful there. Also, if you're opening up the sphenoid sinus, remember that the posterior septal artery lies in the inferior border of the sphenoid os. So those are things that you have to be wary of when you're doing sinus surgery. This is an endoscopic view of the choana and the sphenoid sinus. That black arrow is actually pointing at the posterior septal branch of the sphenopalatine artery. And you can see it's transversing in a horizontal manner right just underneath the sphenoid os. So if you're in your sinus surgery and you're widening that os, your goal is to make a large sphenoid opening, you can see that you can easily damage that posterior septal branch. And it happens, and if it does, it's important to deal with that at the time. Usually, suction cautery or bipolar is sufficient. So prevention is key to stop to avoid these massive complications, right? And so, the anterior ethmoid artery is as mentioned earlier in one of the diagrams, is an artery that lies along the skull base, and in some cases, up to a third of the time, can actually hang in a mesentery below the bone of the skull base. And so it is prone to injury. So you have to be very careful when dissecting along high up on the skull base. Additionally, when you are in some surgeries will require you to cut turbinates, for example, if you're doing like a medial maxillectomy or removing any kind of tumors, or if you just have extreme polyposis and there is a need to remove the middle turbinate, it's very important to prophylactically cauterize the turbinate ends, because these can come back to haunt you in the postoperative setting. They will bleed. Also, consider using hemostatic agents after your surgery. This is just an example of a case in where the middle turbinate was removed, and you can see the blue arrow here. And so the stump of the middle turbinate was cauterized. In rare instances, the internal carotid artery can be injured. Usually this occurs during dissection in the sphenoid. Now, you should note that the carotid can be dehiscent in approximately 20% of the time in node cells. And so that's why it's very important to really dissect carefully in the sphenoid sinus. Sometimes as when you're doing surgery, you may want to take things for granted, but don't. Remember, 20% of the time, the carotid artery can be dehiscent in the sphenoid sinus or in an anode cell. If you do happen to get bleeding by the internal carotid artery, you have to think fast, stay calm, think fast. But it requires prompt packing of the sphenoid artery, so you need to apply pressure. You need to do several things at once. You need to communicate with your anesthesia colleagues. You need to tell them to, remember your ABCs. So the patient's already intubated, but you need to make sure they apply large bore IV access and fluid resuscitation. You need to make sure that neurosurgery consultation and angiography are already consulted for possible embolization, and consider a temporalis muscle patch or some type of patch with non-dissolvable materials. This is just a coronal CAT scan demonstrating the sphenoid sinus, and where the stars are, you can see areas of dehiscence bilaterally, actually, of the carotid arteries. This is an endoscopic view looking at the optical carotid recess, and you can see where the blue arrow is. There is a dehiscent bulge of the carotid artery. Now, not all bleeding actually just exits out the nose. Sometimes it will also enter into the orbital space. And this can cause a retrobulbar hematoma or a postseptal hematoma. And this will ultimately cause intraocular pressures to rise and result in a decrease in optic nerve perfusion within minutes, actually. And depending on if the blood or if the bleeding is venous, you have up to 60 to 90 minutes. Compared to if it's arterial, you have between 15 and 30 minutes time. This patient here is an illustration of a patient who had a orbital hematoma during sinus surgery. As you can see in the patient, they've already undergone a lateral canthotomy and cantholysis, but you can see that the patient has marked proptosis and conjunctival ecchymosis. How do you prevent this from happening? Well, again, the lamina is very thin. And so during your dissection or sinus surgery, you need to really try to avoid violating it. You try to dissect parallel to the lamina papretia. If you're using a microdebrider, try to point it medially away from the lamina. It's also imperative to do several things. Look at the picture, right? Note that the patient's eyes are exposed. It's important to keep the eyes exposed. That way, all along the surgery, all during the surgery, you will be able to monitor the patient's eyes throughout the surgery to note if there's any changes in coloration, if they start to bulge or become proptotic or firm, etc. Also note how the tape is placed. We usually place the tape along the lateral canthi, and basically that allows us to be able to monitor the eyes and look at them periodically throughout the surgery. Additionally, throughout the surgery, we do the bulb press test. It's a really good indicator to let you know if you have any dehiscences. And so this picture really tells you what to do. So during the surgery, we would stick our camera endoscopically and press on the orbit. And as we press, we look for any movement or orbital contents into our endoscopic view. Historically, there was also a test called the fat float test, in which if you thought you got into the orbit, you would take a small piece of biopsy and put it in some saline to see if it floated. I personally have never done that, but I've read that it's not as reliable because you could possibly grab some tissue and it could be an extraocular muscle and it does not float and it can give you a false reading. So anyhow, I think the bulb press test is a good way to let you know whether or not you've caused a dehiscence or have any orbital contents in your surgical field. This is just a figure to illustrate of what herniation of periorbital fat into your surgical field will look like. So you can see you have a large area of yellow fatty tissue. And as you press, the fatty tissue will kind of move into your field. You have to be very careful of manipulation of this tissue, all right? It may kind of look benign, but within this fatty tissue, there are a lot of vessels, a lot of veins, all right? And, there's two different types of hematoma. As remember when I discussed that, they're the type that can occur slowly, and this is usually because of the veins within the periorbital fat are injured. Remember, they can have a delayed presentation. And so if you injure those, blood can build up within the orbital space over a period of 24 to 48 hours. And once it reaches that critical point, it can lead to a decrease in optic nerve perfusion. So again, you have to be very, very careful. In contrast, though, that you could also have arterial bleeding into your orbit, which would cause a rapid increase of intraocular pressure. And usually that occurs by injury to the anterior ethmoid artery. As I mentioned earlier, normally the anterior ethmoid artery runs in its canal along the skull base. However, in about a third of the time, it hangs below the skull base and has a mesentery. Usually it's injured when surgeons are trying to do an ethmoidectomy, especially up high along the skull base. The picture on the left is a coronal CT scan, and you can see with the yellow arrow, the anterior ethmoid artery actually exiting out of the orbit. And there is a like funnel shaped uh, uh, bony appearance. That is the tunnel in which the artery runs. It then proceeds over to the over through the lateral lamella of the cribriform plate. And so again, you have to be very careful, because if it's injured, not only could it cause massive nosebleed, but it can retract into the orbit and cause rapid accumulation of blood into the orbital cavity. So I mentioned this would result in a fast hematoma. Now, if that happens, this requires prompt intervention. So you have to elevate your bed, remove the nasal packing. The tonometer can be used to confirm if you have high intraocular pressures. Typically at this time, we would also try to consult ophthalmology to see if they're available. But, you know, oftentimes they may be in their own surgeries or not on campus. You could try a gentle massage to see if you could redistribute the intraocular blood and allow for hematoma evacuation. But really, the key is, if your suspicion is high, you should not delay in your canthotomy and cantholysis. So how do you perform a canthotomy and cantholysis? So you should liberally inject the surrounding tissue with lidocaine with epinephrine. Next, you should get a hemostat and use that and clamp from the canthus to the outer orbital rim. Usually hold it for about 30 to 90 seconds. Afterwards, you should get some small sharp scissors. Iris scissors will suffice, and cut laterally. Cut from the lateral canthus to the outer orbital rim. From that point, you can then get some forceps, reflect the lower eyelid till you see the inferior canthal tendon, and then use your scissors to cut the tendon to decompress the globe. Then you can also take those forceps and retract the upper lid and cut the upper canthal tendon as well. There's some other measures you can use to help lower the intraocular pressure. You can consider IV mannitol and steroids, but again, these are not instant. They take a while and are generally not really recommended for arterial bleeds. You can also consider a medial orbital wall decompression. This can be done endoscopically or open via a Lynch incision. But the lateral canthotomy and cantholysis is pretty much the gold standard in how to immediately treat and reduce the elevated intraocular pressures. Next, you can have nasolacrimal duct injury. This usually will result in epiphora. So if you have a patient that presents to you after endoscopic sinus surgery and complains of, you know, just tearing, it may be that you injured the nasolacrimal duct during the maxillary enterostomy. It's important to note that the maxillary ostium is really close, less than 5 millimeters posterior to the nasolacrimal duct. And what normally happens is when people are opening up or making the maxillary enterostomy, they actually bring the dissection too far anterior, and they actually bring it anterior to the anterior edge of the maxillary line. So if you look at figure 13, the white arrow represents the maxillary line. And so when you're doing your enterostomy, note the maxillary line, make sure that you do not come anterior to that. If so, you will be prone or increased risk of injuring the nasolacrimal duct. It's possible that during surgery, you could also have extraocular muscle injury. It could be temporary, by having an unintentional injection of local anesthesia into the orbit. This usually is transient, and it can cause a transient muscle paralysis. However, you can have a major injury, and that's usually caused by powered instrumentation that usually results in violation of the lamina. The instrument goes through the lamina and cause destruction of the muscles. You could also have damage by heat conduction from cautery. I've even had damage caused by heat conduction from a drill. And it happened, actually, it was interesting. It happened in the superior oblique during drilling of a frontal, I was drilling out a frontal sinus. So you have to be very careful of your powered instruments. So this slide further illustrates how the extraocular muscles can be injured during sinus surgery. Figure 14 really just shows that, let's see here, especially number C, or letter C, can illustrate how the medius rectus muscle, especially posteriorly, is prone to injury because there's less orbital fat here. And so you can see right in the area here, there is injury to the medial rectus muscle. I also mentioned that the superior oblique muscle can be injured with high frontal recess dissection. You also have to be wary of the silent sinus. Many of those patients will present with a socked-in maxillary sinus. And oftentimes, if you're not careful, you can easily get into the orbit. The uncinate process is glued in and glued to the lamina. And so if you try to just elevate that off, it could cause disruption of the lamina papricia. So also, if you try to enter in your normal level, you might just enter straight into your maxillary sinus, so you have to be very careful. That's why it's very important to just enter it inferiorly and potentially posteriorly. That provides you the greatest room to enter into the maxillary sinus. Also, it's important to keep the instruments away from the maxillary sinus roof. That way it can help you avoid any damage to that, to the orbit. You can have optic nerve injury. Optic nerves, this injury is usually pretty permanent. As mentioned earlier, the optic nerve can be dehiscent in the anode cell. This is a coronal CT scan that illustrates the optic nerves running through the patient's anode cell. Why is that important? And so look at the CAT scan on the left. And so say if you have a patient that's coming to you with sinus surgery, with chronic sinusitis, you've treated them with maximal medical therapy, and you say, okay, you need sinus surgery. All right, during your routine evaluation and review of the scans, it's important to note that there's an anode cell there. Typically, you will see that there's a pacification in that area. You have to be very careful. You don't want to just go in there and try to use Blakesley forceps and microdebriders, because, again, remember, the optic nerve in many cases can be dehiscent. So let's take a look at the endoscopic view of this patient. This is a prime example of why you have to be very careful. Look at the image on the right. You can see the optic nerve in field plain view, ready to be damaged. So you have to be very careful. This is a flow chart that illustrates the pathway of orbital injuries during endoscopic sinus surgery. And basically, what it just demonstrates is that if you have a violation of your lamina, it can lead to extraocular muscle exposure, fat exposure, optic nerve exposure, which then can lead to injury and bleeding and then result in blindness. Or you could have, uh, direct optic nerve injury, or which can lead to blindness, and or anterior and posterior ethmoid artery uh, injury, which can, lead to accumulations of blood in your orbit, which can lead to blindness. So basically, you have to be very careful because any of those main complications can ultimately lead to, you guessed it, blindness. Last, we'll talk about neurologic complications. It's possible for the patient to have olfactory loss. You can have direct injury to the olfactory fibers through the cribriform plate. You can have loss of olfactory epithelium if you're doing a septectomy, for example, like during like a pituitary endoscopic pituitary surgery, or you may have SYNECHIAE that cause the middle turbinate to medialize and actually block the odorant particles from getting to the olfactory nerves. You could also have paresthesias or hyposthesias. This usually occurs when you're doing resections in the maxillary sinus, like trying to remove Haller cells, or if you have polyps or tumors like inverted papillomas involving the maxillary roof. It's common to injure the infraorbital nerve. This figure illustrates the different types of mucosa within the nasal cavity. As you can see, the olfactory mucosa lies medially along the superior third of the nose and borders the cribriform plate. Figure 20 illustrates the course of the infraorbital nerve. As you can see, it runs along the roof of the maxillary sinus. So again, if you have any pathologic process that you're trying to remove within the maxillary sinus that's along the roof, if you are trying to dissect that or use a microdebrider, it's possible to injure that nerve. The next type of neurologic complication is a CSF leak. This usually occurs, or most commonly occurs, by penetrating the lateral lamella of the cribriform plate during ethmoidectomy. It can also occur if you're doing a draft 2B or 3 during frontal sinus surgery. It can occur during sphenoid surgery, and if you're being too aggressive during your middle turbinate resection. Risk factors include pre-existing skull base dehiscences, or if a patient has a low-lying skull base. You have to be very careful in patients when you're dissecting high along the skull base. And so prior to prior to operating, you have to review the scans. And we kind of mentioned earlier the closed mnemonic. And so we'll kind of look at this again and just kind of, we will go over things that as a surgeon that you should look for. And so it's important to look at the skull base. You want to make sure that there's bone all the way throughout. You want to make sure that there's no dehiscences. You want to make sure that the cribriform plate is at, well, you want to look and see what the level of the cribriform plate is. Is it a low lying skull base, or is it a high skull base? You want to make sure that there's no asymmetries or, or masses that could complicate things. You want to look and see where your anterior ethmoid artery is. You want to make sure that you have a true understanding of the patient's anatomy prior to you beginning the surgery. So you heard me mention the Kuros classification. This is a classification that tells you the height of the skull base. Well, what does that mean? Basically, the height of the skull base is the length of the lateral lamella of the cribriform plate, or in other words, the distance between the cribriform plate and the ethmoid roof. Why is that important? Well, the deeper or the longer the lateral lamella, the lower the lower the skull base is, and the more likely the patient is to have, or the more at risk the patient is to have a complication. And so why? It's because you have to be very careful during your dissections, especially medially. And so during sinus surgery. So how do you prevent a CSF leak? Well, you need to know where your skull base is at all times. Make sure you know your orientation by using known landmarks, right? Your middle turbinates, your choani, make sure you know where those are. Your sphenoid sinus. If you're disoriented, slow down, okay? Also, remember, the bone is very thin medially. So if you're dissecting along the skull base, tend to dissect laterally. That's where the bone is thicker. Use navigation to confirm your location. Make sure it's accurate. Every millimeter counts. Also, this is just a tip. Be wary of just doing biopsies for polyps that are medially along in the olfactory cleft. Oftentimes, they are mistaken for polyps when they're actually meningoencephalocele. So if a CSF leak is encountered during surgery, prompt detection and repair is imperative. This helps prevent further complications like meningitis, abscesses. This is just an illustration of a repair of a CSF leak. Here we used a inferior turbinate free mucosal graft. We inked the mucosal side, so we'll have the mucosal side out into the nose, so you can see the blue ink, and we put a patch over the defect, put Duracell glue over it, then I put a nasopore on top of that to hold it in place, then I put more Duracell glue. Besides the CSF leak, it's still possible to have catastrophic complications such as intracranial penetration and removal of brain tissue. A lot of times this can occur in a setting of excessive bleeding or poor visualization. It can occur in the use of microdebriders or co-bladers along the skull base. Many times people think they're going in one orientation when actually they're angled a little bit further up. I've actually seen this in the case where even people were doing septoplasties where they thought they were going straight posterior and they were actually aimed up towards the brain. So you have to be very careful. You have to stay oriented at all times. So now we'll discuss our conclusions. So in conclusion, there are several principles to avoid complications in endoscopic sinus surgery. You should master the sinonasal anatomy, including common variations. It's very imperative to review the pre-op CT scans in a systematic fashion and anticipate high-risk areas. You should maintain good surgical habits and consistency in your technique and avoid an excessively bloody field. You should effectively use your navigation system, make sure it's accurate, safe, to use, and recognize your complications early and intervene to prevent further complications. Key points that you should take home. Preparation is key to prevent complications in endoscopic sinus surgery. Remember, pre-op CT scans can help identify risk factors for complications. Good surgical habits will help you avoid major complications. Most major complications occur in the setting of bloody field. Most major complications can be minimized or fixed if recognized early and promptly intervened. These are suggested readings. These are my sources. Thank you.